and welcome our guests from hospice. We're so happy to have you here, and thank you, Barbara, for organizing all of this. And I've already introduced Chris, so why don't you just start out, and if you wouldn't mind just stating your name so that everybody can hear you, and what your role is and where you are currently stationed, we'll say.
I'm Chris Galea. I'm a third-year medical student, also oral surgery resident. So I'm doing both my MD and oral surgery training here, and I'm on my 1-week palliative medicine rotation as a medical student.
You kill people and you're a dentist? That's why we don't like to go to the dentist.
Bad combination.
I'm David Grant. I'm a postmaster's A&P student from St. Louis University. Finished up my work, graduate next week. My MSN is from George Washington, and I'm hoping to someday practice in palliative care.
I'm Tara Beck. I'm the chaplain on the palliative care team at University Hospital. Worked at hospice before that.
Yeah.
Frank Vaughan, I'm the clinical pastoral education supervisor at University Hospital. And the stars have aligned, and all these people from my past are, I worked with David at the palliative care unit at Baptist East. Jim England did my wedding.
Ooh.
He was a child prodigy.
Oh, I see.
I'm Kelsey Blankenship. I'm a chaplain resident at University. I'm also incredibly intelligent, and
And then you get a job.
I have a contagious personality, and I'm looking for a job. Plug it in where I can.
Bill Owens, chaplain resident, also UL.
Philip Garrett, chaplain resident here at University Hospital.
I'm Mary Hubert. I'm a palliative medicine attending at the Brown Cancer Center Clinic.
Karen Cassidy. I'm a nurse practitioner at Jewish and St. Mary's.
I'm Becky Fudge. I'm a palliative care coordinator at Jewish.
Ruth Simons, palliative care attending at Jewish Hospital and St. Mary Elizabeth Hospital.
I think everybody knows me, but I'm Lauren Earnshaw. I'm palliative care doctor at University Hospital and director of the fellowship training program. And our fellow is currently walking, maybe running. So if we just wait a few minutes, we'll embarrass him and introduce him to everybody, and then we can get started.
Okay, good. We can introduce him late. Okay, great.
Are you going to introduce everybody?
Yes, I am. Yes, I am. Okay, welcome everybody. Today our topic is interdisciplinary team, and there's no better way to learn about interdisciplinary team than from the experts, as we know. So we're going to do a little interface between some of the things in the literature about teams, but we're going to talk with the real experts today. And you know, I'm never going to need a hospice team. I don't know about you all, but I'm not going there. But if I were, this would be my dream team. So these are the best of the best. I can tell you that from working with them years ago and just knowing them professionally as colleagues and as friends. So I want to introduce them to you. On my far right is Jim England. He's chaplain at Hospice. And Jim, what teams are you currently on?
I'm on an adult team, also the pediatric chaplain.
Pediatrics. And sitting next to him is Joni Prentice, who's a nurse at Hospice. And are you on an adult team now, Joni? Yeah, okay. And then next to her is Kim Arrington. And Kim, what teams? You're on rural counties now, out in the rural counties. And Kim has also had the experience of working in an oncologist office as the social work and facilitating the needs of oncology patients related to palliative care. So they bring a wealth of experience. How many years altogether do you three have it in hospice? Joni's 20. 19. What about you, Kim? 18. So they are the experts. They truly are a dream team, and as I always like to say, we are well seasoned, right? So we're going to start with a few slides and, well, one slide, and then they're going to interact with the slide content, so we'll go back and forth. If you have questions during the presentation part, feel free to ask those questions as we go along, and let's be as informal and interactive as we can. When I talk about interdisciplinary teams, I always like to start with this quote by Balfour Mount. He was the father of palliative care in the hospital setting up in Canada, and a wonderful hospice leader, palliative care leader. But what he said about teams was, if they don't have scars, they haven't worked on a team. So, team member, oh, and I forgot to say one thing. You will know we don't have a physician sitting up front, but we do have experienced palliative care physicians in the audience who are going to serve in that role, Mary and Ruth and Lori and Clint, in terms of the physician's role on the team. So they're going to chime in whenever they can or want to. Okay, so how would you all react to that quote by Balfour Mount?
Absolutely. If you don't have scars, you haven't worked on a team. Because there's a lot of stressors when you're working together. You come from different vantage points, you come from different fields of expertise, and you have different opinions on maybe how a situation should be handled. You have different working styles. There's inevitable conflict, and it's how you handle that conflict and how big or bad your scars are, that you'll have scars.
I like to say it's not just in the beginning either.
No.
It's all
ongoing.
Well, I think when you've been around a while too, you get to know people and to trust them, and to trust them with what may feel like negative. And you're not afraid to say it, and you're not worried about how they're going to hear it, because they're going to hear it because we're focused on what is best for this patient, and we're batting that around back and forth. I can trust Joni if I say something, I don't see it that way, Joni, and know that she's not going to get all bent out of shape about it. And she can tell me I'm way off base in my assessment of how I see this person. It's not going to bother me. I'm going to realize that as a nurse with lots of experience and as a human being, she sees things differently than I do. And it helps me in my understanding of the spiritual needs of this person.
Kim, do you have anything to add?
Well, I think as people come new to at least our work, they can feel real beat up at the beginning just because there's so much to learn, and you're challenged a lot. And if you haven't been on a team before, it can be a new experience to have all of these, and then you have people with lots of experience who are bringing some really good things to the table. And so for our new people, even if they're not feeling beat up, they're maybe not right out there putting out what they need to be sharing because they don't trust necessarily.
Maybe breaking in an established culture can be hard.
Well, I also think with practice on a team that you're very vulnerable, that your whole team sees and evaluates your practice. And practice is not always perfect. I mean, we all run into patients that we just don't jive with. Maybe they don't want us to be their healthcare provider. You might even call in. They used to call in sometimes at hospice and say, don't send that nurse back. And there you are in front of your team, and it's going to happen, and hopefully your team is going to support you. But you're very vulnerable. It's not like you go in a room and close the door and do your work with a patient. It's like that's all shared. It's all out there in the open. And that can be a wonderful learning experience if it's supported and you have that trust with your team. But it's also painful in a lot of ways to put your practice out there and work with other people day in and day out. But when I think about this quote, I also think that scars are a lot tougher than the open wound. So once you've healed, you become a better, stronger professional. You know yourself better, so you've grown. And it's a good thing to have scars, to be kind of beat up like it happens over time. Any other comments on that? Any physicians have any comments, or are you all above the bruising and the battering that goes along with interdisciplinary practice. Okay.
I'd agree with it. I mean, I think that you're not being honest with each other if you don't have some scars. And then
Right.
nobody's going to grow professionally or be the best they can be if we're not honest with each other. As long as you know you're coming from a place of mutual respect, then I
Right.
feel that it's productive and good.
Mm-hmm. Right, right. So this is kind of a theoretical definition of a team. It's a small number of people with complementary skills who are committed to a common purpose, performance goals, and approach for which they hold themselves mutually accountable. So looking at that, I mean, small is kind of a nebulous term. What do you all think is a good size for an interdisciplinary team?
Palliative care specifically?
Mm-hmm.
4 or 5 is what we usually work in, I think.
Mm-hmm.
For us, we look at the disciplines.
Yes.
The nurse, the social worker, the chaplain, our CNAs, our doctors, maybe our community doctor, maybe our medical director, and then our volunteers. And then our bigger team, those are our direct patient care people, but then our bigger team are the people that we call in the back of the house that are supporting us, our managers, our assistants, our team assistants, maybe that do clerical stuff. You know, it takes a great bigger team to make the whole thing run.
Mm-hmm.
But the direct care providers, I'd say ours is probably around 6.
Mm-hmm.
Well, even the hands-on people's 4.
Yeah.
So those are they're the ones that are in there with the patient consistently. And what I've always been fascinated with, you know, the people that we perceive at the bottom of the totem pole, which is like the CNA, you know, those that don't have the, you know, the training and that the rest of the experts have, are the ones that are in there with the hands-on more than anybody. And really, I think our CNAs are invaluable to the work that we do, because they get in there and they hear things that the rest of us don't.
We have a lot of 20-year CNAs.
I think they're the most appreciated. Certainly were when I was in hospital. They're the most appreciated team of the patients and families.
The CNA has hands-on, and it's a very intimate kind of thing.
Yeah.
You give somebody a bath, help them, or you go to the bathroom. And they tend to open up and share something with somebody when they've been that intimate.
It's a real art to being a really good CNA. We've got some really good ones.
So you would see team as defined by the patient. So it would be all the people that take care of that patient. That would be that patient's team, right?
And I would also add that we are also there to support each other, because there are times when a family, for one reason or another, will decline the services of the social worker and the chaplain, and they'll only let the nurse in. And I still work with the team in those situations because, by golly, I'm working with my social worker and my chaplain to help, number one, figure out ways to get them in. And I'm pretty good at it. But they provide support for me as I go through sometimes those are the most challenging and difficult cases, because this is a family that, you know, they've got their little circle, you know, but sometimes it really does need that interdisciplinary approach, and those are usually the families that need it the worst. And so I find then that I rely on my team members, even if they're not indirectly, even more.
I think that when you're looking at a team, and I've been on other teams, like I'm on the transplant team, Jewish, and various transplant teams and stuff like that, and those are mega big teams. More than twice the number in this room. So I have a respect for the word small, and small being enough that you can comfortably sit in a semi-small space and actually have a conversation, because if you get too big, and even this I think is too big, so when I read about all of the other, team members, it's like, yeah, but if I had all those associated ones, then we're getting too big, because people don't have a voice, they're just kind of lost in the crowd, they can zone out. So I think that 4 to 6 makes a lot of sense for a lot of reasons.
You can really intimidate a patient and a family when you come in with numbers, even in 4 to 6. So So I think that team is fluid, and I think it does depend on the patient and family and the need. And
the size of the space.
Yes, and practical considerations like space, absolutely.
Yes, Karen?
You wouldn't formally consider the patient's caregiver or caretaker part of our palliative team, but in that definition, they would be a part of the team.
Right. Right.
Part of hospice philosophy is this: to equip the person who's doing the caregiving with the understanding that the people who love this person the most will make the best caregivers if they just have some training and some coaching. Because they're more highly motivated than anybody else is.
Right.
They're the center of the team.
In the same way that the hospital staff, the nurse that's taking care of the patient is part of the hospice, the palliative care team. Because she's just an extension of us, and part of our responsibility is equipping her with the information that she needs in order to carry out the care of the patient.
So the team is really defined by that common purpose. And it could be that, say at hospice, you have a team where the teams are kind of fluid, where if you defined by the patient and their needs, but it changes from time to time based on the focus for that patient. And I know in the palliative care setting in the hospital, often you have family meetings and involve the patient, and also the caregiver and the other family members is really part of the team at that time. And I know it's a little bit more difficult with patients at hospice, but I do know there's a research project going on where they're Skyping patients into team meetings to see what impact that has on the plan of care and the communication between the team and that patient. So it's an interesting thought that the patient should always be a member of the team, or the caregiver. Sometimes we exclude them, and I'm glad y'all pointed up the CNAs. I feel bad that I didn't invite one to come, because they are so key, and we just kind of overlook them, and I did that too. So not all groups are teams. We all know that. We wouldn't want every group to be a team, because a team has a defined purpose, and it can, we need to look at when a team is effective for the outcomes that we want. A group can come together to work, and there may be strong leadership in that group. Each individual is accountable for doing their piece and, say, reporting back to the group. They have individualized work products that they bring and share. Meetings are geared toward efficiency, and success is often determined by the influence that team members have on other people, where with the team we have shared leadership. Everybody's accountable for the outcomes. The work products are more collective efforts than individual efforts. Discussions may be very open-ended, where there's active problem solving, brainstorming, innovative ideas are allowed to come forth, and the success is the collective work products. And it's important to remember that it has been proven that interdisciplinary teams have some very important outcomes. The top priority would be, of course, better outcomes for the patient, and that's been proven in terms of more continuity in their care, better symptom management, cost effectiveness in terms of getting them out of the hospital, keeping them out of the hospital, providing continuity of care. Patients and families are more satisfied when an interdisciplinary team is involved in their care. There's more productivity in most cases when you're dealing with people. And the staff are more satisfied when there is an interdisciplinary team working together effectively on good patient outcomes. So there's a bunch of little sayings out there related to teams, and this one I kind of like. Team means together each achieves more. And I was wondering if any of our panel members had maybe a case example where, because there was a team, the outcomes were better for the patient.
Well, I thought of one mainly because my family was a recipient of hospice care just a couple of weeks ago. And like all families, there are no Beaver-Cleaver families, by the way, and we certainly have a Beaver-Cleaver family. And we had a situation where our family member was at home, wasn't getting the best of care. We had a hospice home team, but she needed to go into the hospice inpatient care center to get some symptom management. So we coordinated with a hospice home team, then we coordinated with the hospice inpatient care team, who coordinated with her caregiver partner, her family, and her other family members. And her death was very peaceful. The symptoms were very well managed. They had a family meeting up on the inpatient care center that helped all the different people coming from very different perspectives of what end of life should look like, or that even end of life was coming. That was the biggest issue, was surely it couldn't be happening. So to have that space and all of those trained professionals working together, they helped a really wide variety of people kind of get to a place of acceptance that death was coming and that she was able to die very peacefully. So I saw that as huge, just from a first-hand experience of seeing how home team blended into the inpatient care team. Chaplains were involved, social workers were involved, the aides were involved, volunteers were involved. It was really, really beautiful. It worked really well.
Can I just ask a question? Because you made a comment earlier about how sometimes you deal with difficult patients or difficult families who are very, I think, maybe controlling, or they have an idea of how things are supposed to be, and they're not very open to inviting other interdisciplinary team members in. And I just wondered, it sounds like you go to your interdisciplinary team members for support. And were there any examples of how, you tried to go with something solo and learned maybe the value of that team from trying to address things more on an individual level and just getting beat up? I just wondered if you had any examples of how it's more ineffective working as a sole provider, and how you work with the team when they're not invited into a situation.
I think early on in my career, I worked with a very, very strong social worker. I worked with Janet, and she was really, really well trained, really knew her stuff, and I really didn't. I was a new nurse. I thought I was a super nurse. I could do everything, and Janet would call me to task every single time I would, go in there and try to think that I could do it all by myself. She says, "Why didn't you call me? I could have helped you with that. I could have made your job so much easier." And she trained me over the years to get a whole lot better and a whole lot more, a better team player. That's invaluable. And it helps the family have a better experience when more than one person's involved. I hate to be the only one involved now. It just doesn't feel right.
But that's not, in your experience, is that really part of your training, though, and your education? You probably didn't really learn that in school. It's something you learned on the job, huh?
I kept a notebook of the things that she would say that I liked. I just kept a little notebook that said, okay, these were Janetisms. She'd have a way of phrasing things that made the conversation open up so much better, but that was not part of my training. I didn't get those kind of communication skills as a nurse back in the 70s.
Working on the rural team, I have some really difficult social circumstances that, no, the team does. And I had a case recently in the back part of Spencer County. It was probably one of the saddest situations I've come across in a long time. And the family, it was a couple, they lived in this trailer, they were estranged from all their family members, and they really had no money. It was really, really sad. And it was a challenge for us, and he was a veteran, so we worked real closely with the VA too, because he ended up in there twice. And it really took the whole team. There was no way anybody could have done it on their own, because there was alcoholism and drug diversion, and it was just awful. And with all of that, the guy wanted to die at home. So you've got, lock boxes in the house, and you're counting meds, and, the last time he went to the VA, he went in because we thought he was terminally restless, and we were giving him like 40 milligrams of morphine at a time, and it wasn't taking care of him, so he goes in there and he actually gets 3 doses, and they have to give him Narcan. So then it's like, okay, so what's he taking it home? And so they discharge him home on 5 milligrams and they will not increase it. And I mean, it was just one of those where the nurse and we got a CNA in there and the chaplain, I mean, we were probably out there, I know in his last week I was there probably 3 times. Because you couldn't, we were trying to keep him comfortable, and we were trying to do it with her and keep her comfortable, and keep him safe. And he got a they made us give him take a urine specimen because they weren't going to increase the meds until they knew what was in there. Well, he died and then he came back, and there was nothing in his system. I mean, it was like it was a nightmare, but. We all made it happen because she wanted him there too, but then her brother had been carried out of the house and she was afraid of seeing that again. I mean, it was probably, and then I went back Thanksgiving weekend because she was threatening suicide, and it's just one of those, it just doesn't end. But it took absolutely everybody to do that. And then some. On call, and now we've pulled in our bereavement team to do phone stuff with them. So, yeah.
Right. I had a situation where I was not part of the original. I was part of the original team, and he didn't want the chaplain. And the reason was he had done prison time. Didn't have much need for God, as he put it. But he got suicidal, and the team got afraid that he was going to kill himself. And they convinced him to let the chaplain come in. And in talking with him, he would say things like he wasn't worth the bullet it would take for his brain pan. And he would talk about breaking into pharmacies to steal the medications that he now had to have to control his pain. And he said he'd never done a worthwhile thing in his life. And I didn't argue with him, I just kept him talking. And he eventually said something about helping a nephew tune up a car. And I would stop and, well, Charlie, you said you've never done anything good in your life. Well, I haven't. Well, your nephew thinks tuning up his car was a good thing. Yeah. Then I kept asking, anything else like that? And he'd struggle, he'd think of something else, and I keep saying, anything else like that? Until finally he named off several things like that, and you could just see the light come on. Well, maybe he had done some good things. And from that point on, he was a lot easier to work with. He eventually asked me to baptize him. He's 6'4" and I'm not. Around that day. But he said something very interesting at his baptism. He was dancing around from foot to foot like a little boy had to go to the bathroom. And he said, I know I have God in my heart, and God has me in his heart. Which is a long way from this guy who didn't think he was worth a bullet for his brain pan. And it just made everything smoother because the whole team was involved. Nurse addressed his pain, social worker helping his spouse, and he was willing to talk to me about his own sense of worthlessness.
And he was accepted by this strange group of people.
Yeah.
For who he was.
That's wonderful story. Wonderful stories of how the whole picture can change when there is a team in place. But in any of these situations, it could have been easy for some person to say, oh, I can handle all this, a team member. And Joni, you could have chosen to really be affronted or offended by a social worker trying to tell you to let them do this or that, So a lot of it has to do with attitude, and the willingness. It really leads us to this slide, which talks about the willingness to teach each other, to ask each other, to motivate each other, and also to empathize with your other team members. And what are some of the things, I think you've covered some of the things that you've been able to teach your other team members so that they respect your discipline and you work together more effectively. Can you think of any other things that you've learned maybe from other disciplines or you've been able to teach your team members?
I think working with the same team members, and I've worked with this current makeup of team for a pretty long while now, and they're used to the way that I explain approaching death, science of approaching death, and kind of my style of working depending on kind of educational needs. I think of the family, they're used to that, and it's so good to hear them. They'll reinforce it. You know, I'll hear them on the phone. They'll be using some of the same language so that the patients and families are hearing the same thing over and over again in repetition from different disciplines, so that they really start taking it in and feeling it and knowing it and feeling a little bit more confident with what they're doing.
Right.
I think something that's been really helpful about being on the team is also just kind of like personal health and personal mental health, is that since the work we do is so, can be really draining and taxing emotionally, it's good to have team members who can be there to support you and listen to you and help you, and since they know what's going on, they know the circumstances of the situation, they're really good, they're a good resource to help. So, and it's always good even just to have somebody just to say, good job with, with what you did with this person.
Right.
I was going to say, one of the nurses that I work with now, is the way we're set up is it's like a nurse and, no, it's not. How do you do it?
One
Nurse
social
is one
worker.
social worker.
And a half a chaplain.
And a half a chaplain. And I work with 3 nurses. My team has 3 nurses with varying degrees of hospice experience. And I'm trying to think, I think it's the newest one on the team had worked on an inpatient unit in Florida and came out. She liked our team. She did some coverage, and so she wanted to be on our team. So she came out and has Spencer County. So she was like all over the place. Really, you're a lone ranger at times, even though you're connected in all kinds of ways. And I've had to really remind her that she's on a team, and that you can call me. I don't always know because I've got way more patients than she does. So. I'd say, if you come across a social situation, you have a question, call me. You're not there by yourself. There's Todd, there's the CNA. So I've had to tell her that over and over again. And she's beginning to get it. But if you're not used to that, she was used to the inpatient unit. She didn't have patients for very long, and even though they would have had those team members, it's just a whole different dynamic to being out there. In your car with your cell phone.
Right.
I think just, oh, no, you go ahead.
I was just going to say, when I train new nurses, I always give them my cell phone number, and I'm really, really worried if they don't call me. Because if we've got a new nurse at hospice that doesn't have any hospice experience, and they're out there on their own, and they haven't worked in a team format before, if they're not calling, it really worries me a little bit. And I'll check in with them every once in a while and say, have you come across any things that, have kind of stymied you? How are you using your team members? Are you calling your social worker? Are you communicating? And I think that's really important when you're training new people to make sure that you're checking in. We're real good at doing the checklist, check off all the boxes, sign them off, and then throw them out. And then just, sink or swim. And I think it's so important to continue to follow up with new folks, at least for the first couple of years, forever as far as I'm concerned, but at least for the first couple of years pretty intensively, to mentor and to make sure that they're learning teamwork skills and not trying to do it all by themselves, because it's a setup for burnout. It just is.
Well, I just had a question for all of you, and Barbara, you too. I just wondered if a lot of what you learned to do, I think people come into this field just with this passion, and we're gonna just stamp out suffering, and we're gonna make every death a good one, and I think that people do come in with some pretty high expectations of what they can actually do and what impact they will have, and I think that a lot of what the team helps with is to help you understand that sometimes just being there, and as Tara talks about, unconditional positive regard, providing that and just doing the best you can. Sometimes that's the best that you can do, and I wonder, I think that's where the team can be helpful too. Is just not only recognizing good work, but also helping us be accepting of the limits that we have and what we can do. I wondered if you all, felt that that's a challenge now that you're further along in this, or is that less of a challenge now?
Oh, I think it's an ongoing challenge. I've done this 18 years, and there still are times where I feel like, do I really know what I'm doing?
Mm-hmm.
You know, why?
So it doesn't go away.
Why am I not? What's wrong here? Why? What's not connected?
Mm-hmm.
And so it's the continual, put my stuff over here. What do they really need?
Mm-hmm.
Just because I know what we can do for them doesn't mean that that's what they need or they want or
Or
they'll
they'll accept.
accept.
Mm-hmm.
So,
Mm-hmm.
you just have to,
Mm-hmm.
step
Years
back
ago.
and go ahead, Jim.
Years ago, I sat in on a conference with one of our pediatric patients. Her mom wanted to change something that was pretty important in this child's care. And the team of physicians were discussing it, and there was one who was, I thought he was incredibly rude to her. He never laid eyes on the child, never been in the same room with the child, but proceeded to tell this mother that if she did this, she would kill her child. When I got back to the office and meeting with my adult team, I was carrying this upset, and I'm not allowed to tell the doctor what I really think. And my team asked me how it went, and I started to tell them, and then I started to weep. And they were so accepted. Nobody said, hey, big boy's gonna cry. Or don't do that makes us uncomfortable. Nobody did that. They gave me space, they gave me support, they gave me this empathy, even though they were my adult team, not my pediatric team. And it was very helpful to have a safe place to go and do that, rather than to carry all this back to the next encounter with that same physician. All due respect to all the physicians.
We had suicide on our team last week. I mean, not our team members, but one of our patients committed suicide last week. And the nurse and the social worker that found the patient and dealt, with all of that, immediately the rest of our kind of extended team, there was multiple nurses in our bigger team, took over that nurse's patients, but automatically a social worker was helping back up the other social worker, and those two people shut down and just didn't see any more patients that day, got to go through the whole debriefing of the impact on that suicide that had on those two people that actually found the person. So I think just the amount of support that we provide one another is just huge. I certainly would want to do it as a voting ranger.
Right, that's wonderful. So the whole idea here that there's no I in team, that can be a very good thing, losing that I and truly having the support of other people, not feeling totally responsible, being able to share not only your success but also the burdens, the tough death, the family from hell, or the borderline personality that's driving everybody on the team crazy. Just to have that camaraderie can be such a strength in doing this kind of work, because we know that teams are needed in palliative care just because of the multitude of problems that people face at the end of life. And it is a whole person experience to die. It's not just a medical experience or a social or spiritual experience. It all comes together at that point in a person and a family's life. And so the various skills of the team members are all essential and all important. There's been a lot of terminology thrown around in describing teams, and I think we need to look at that for a minute. Unidisciplinary team, of course, that would just be a team of nurses or a team of physicians, and we see that in different settings, and that may be effective in those settings. What I see a lot is multidisciplinary and interdisciplinary gets confused, and I'd like to kind of discriminate between those two terms. Interdisciplinary refers to a team that is really on a higher plane, like a perfect team where they allow a lot of role blurring, a lot of lucidity and fluidity among the team and how they function. So that's kind of an ideal, maybe a goal for hospice type teams. I've heard it used more as that perfect model. I'm not sure how often that occurs, but we'll talk about that in a minute. But looking at, let's step back and look at multidisciplinary versus interdisciplinary. And like I said, these words are often used interchangeably, and they are not interchangeable. For a multidisciplinary team, every team member has their discipline-specific goals and interventions. So this would be a team where everybody goes out and does their assessment, they build their own care plan for that patient, they might come in and present it to the team, and then they go back out and do their part. But there's not a real focus on all team members being directed towards certain goals for that patient and family. In multidisciplinary teams, there's usually one discipline that leads all the time, while in interdisciplinary teams, leadership changes based on what problem is the high priority or what goal the team is focused on. With your multidisciplinary, roles are distinct. Often they use standardized care plans, so there's not this planning together for the patient. And it's more the traditional medical model with a multidisciplinary team. The article I gave you a copy of, Martha Twaddle and another physician wrote that, but it talks about the multidisciplinary team being like a pie. All the pieces come together, but they're still very separate. Whereas the interdisciplinary team is more like a hand, where every finger has a function. But in order for anything to happen, the hand has to work together. So it is united and works together in terms of accomplishing goals. So would the panel agree with that differentiation between multidisciplinary and interdisciplinary? And what's your understanding of transdisciplinary? Have you heard that term used? No, not too much. It was really, I think it was coined by David, what's his name, up at Hospice of the Western Reserve?
Weissman.
No, not David Weissman. He was the executive director of Hospice of the Western Reserve, and he kind of promoted that idea of transdisciplinary, where there's much more blurring of roles and interface.
I've heard it used. I have a problem with it, and that is it's too often just an excuse to not have good boundaries.
Right, right. So, and that brings us to that concept of role blurring, which often in the literature it talks about role blurring and teams being able to be flexible about roles, but yet having distinct responsibilities. So how do you see that play out, or do you not like that idea of role blurring?
Well, I think in the work that we do, it's kind of hard for it not to happen a little bit, and I think it's, where I see it most is we all do a little nursing stuff every once in a while, because you're going in there and we always have to assess for pain, you know, so, and I can tell when somebody's in pain, and I can tell when they're terminally restless, and so I may say, well, when did you get the medicine last, and that kind of thing. I don't always feel comfortable with that, and I'll typically, if they have any hesitation about it, then we call the nurse, you know, but, you know, sometimes that's what happens. I do get uncomfortable when I encounter some team members who might try to be a chaplain, because I really don't think, you know, that I don't go there. You know, I call the chaplain because I'm not comfortable with that. I think there sometimes when if somebody hasn't worked with a social worker and doesn't really understand what all social work is and what we do, then sometimes I've encountered at times nurses who think they can do that. You know? And sure, you can give out numbers and resources and all like that, but there's more to it than that. And for the most part, I have really good nurses who know, you know, who say, I'm not going there. That's fine. You go there. You deal with that. So I don't know. I don't know what your all's experience is, but
I would argue with you about the comment about the chaplain, because I would think if you had a patient who is just suddenly able to open up and talk, I'm not going to say, put a lid on it while I get the expert. I'm at least going to listen.
What I'm saying, going into the deep spiritual stuff, I mean, I'll listen, but I'm not going to take that on as that's my role. And I'm going to even try and help I mean, I agree with you. I don't turn it off. To myself, I'm saying, I'm going to be careful here. Okay? I'm going to be careful because this isn't my area of expertise. And then find a way to say, well, have you thought about talking to the chaplain, or has the chaplain visited? Because that's the kind of thing that they can explore with you.
I think sometimes the patients get confused. I had a hospice patient, and I went and talked to her, and she's like, oh, the nurse was here, and I told her all this and all this, and there's all these symptoms and all these problems and all this medical stuff. And usually the hospice nurse will call me as a doctor and say, my patient has this and this, can we do this? And I got like no call, no nothing. I'm like, what kind of nurse is this? And then come to find out it was a social worker. But the patient, I think, probably thought she was a nurse and was telling her all the medical stuff. But it was just really, really confusing because it was like, well, why didn't we, but the social worker didn't, I don't know. Maybe the social worker thought it wasn't that big a deal, or maybe she was going to call the nurse or something, but then none of those symptoms were really addressed. I mean, from my perspective, I mean, who knows the whole story? I mean, she did two sides of the whole story, but then I was like, well, once I called hospice and said, well, who went out and saw this person, and it was like the social worker, then I talked to, then I called the nurse and said, well, the patient's having all these symptoms and stuff, so it was just confusing. So I think sometimes it's really, everybody can do everybody's role, but I think it's really important to kind of make sure that the patient knows who you really are,
So we're all nurses.
But you did tell the patient just thinks everybody's a nurse.
That's a really good point, that you clarify roles with the patient, but
they sit down and they start telling you the medicine.
Right.
Exactly.
But in a way, that's good because they see you all as members of one team, so they.
If I could go back over here for just a moment, I think the issue about the transdisciplinary, particularly involving the chaplain, who initiates? If a patient initiates, then I think whoever's there needs to listen. If I go in, or like I heard one nurse said, well, I go in, if I see a Bible, I just open up and start reading it to them. I think she's so far out of bounds.
Right.
They have no understanding of all of boundaries, and I think she's dangerous.
It's a good point.
On the other hand, as a social worker, we take them where we find them. So
Right.
if someone in their grief or their pain or whatever make a spiritual statement, we can support them in that statement. We don't have to go anywhere with it, but we can support them where they are. So we can, in our role, support the nurses, support the chaplains, support the social workers, support all those by just reaffirming where the patient is.
Absolutely.
I think what Jim said earlier about having really good boundaries is so important in the hospice team. I mean, it is to me, and it is a way when families have declined social worker and chaplain, when those kinds of issues start coming up, that's when I'm starting to work my spiel of here's how you can get, your social worker involved, because once we start talking about caregiving, I say, that's really not my bailiwick. I said, but Sherry is so good at it, and you just really enjoy talking with her, and she's got all kinds of options that I might not even think of. Or, if they're seeing that they really need to talk about it, I said, you know what? I wish you'd let me call Rosemary and let her come out and just sit with you and let you talk with her. You seem really angry about all this, and I know that she could do a much better job than I can. And I really work hard to get my other team members in because I frankly hate being in there by myself. So I just think it's really important to really look at those boundaries. And I can listen, I can pray, I can read, I can do all those things. But what I want that patient to have is the expertise of the best person for them, and that's my teammate.
Yes, Brock.
I also think it's a question of professional ethics there, and along with the boundaries, to practice my care according to the training that I received and to the expertise
absolutely.
that I have. I think interdisciplinary competence has to do with each discipline seeing that there's more than just my part to it. I mean, how it fits together, then referral that's a competence in itself, to be able to make a referral and to get somebody else. And sometimes I think half knowledge is worse than no knowledge.
Right. So you kind of walk this fine line, because when you're the only person there with the patient, you want to respond to what's going on with them, but yet you want to be sure they get the expertise they need, and that you're using your other team members and that they're benefiting from those different skill sets. So I think that's a point where maybe the team teaching of each other can come in. For instance, Joni might ask the chaplain, so-and-so asked me to pray with them the other day, and I went ahead and let them pray, and I prayed with them. Is that okay? And Jim could give some advice related to that. And because I do think so many things are in the moment for our patients. Like you said, Joni, about being on time. Their time is precious. And so we have to know what to say, how to respond to some of those immediate needs without overstepping our competence, as you said, Frank. We're not trained to do all those things, so we shouldn't, be doing them, but we do need to be responsive.
And that's a hard thing to teach the fellows, too, because, in geriatrics, we just hired a social worker, and so we're so used to just doing it all ourselves. And it's like, this is really something the social worker can do, like, so, you don't spend 2 hours with the patient, stop and then let the social worker do stuff. So it is a skill to teach, like, it's a competency of, like, how to use your team, And
Right.
So it's hard, and you have to really be conscious of how to do that.
Right.
Yeah, I'm sorry.
I was just saying, many times patients feel more cared for and families feel more cared for the more members of the team that are involved. On our team, we work it out so that we're visiting on different days as a rule. So if we've got somebody out there 5 days a week, that family feels so much more supported than if the nurse shows up once a week, and tries to take care of everything. So if you're spreading it out, they also feel more cared for.
Absolutely. Clint, you were going to say something?
Yeah, I was actually thinking about this morning as far as like what's my role in each of the disciplines, and so what's my role in the spiritual discipline, what's my role in the psychological, which is the social, and then the medical. And because I was printing out some charts to review, and one of the people on the team said that it's been an issue at the VA because they have like a template when you do your notes, and they had, I guess not long ago, removed the part on the doctor's template asking about what is this patient's religion, spirituality, what's the social situation, saying that that's not our role to address, that's the role of the rest of the team. But looking at what my training includes, I have to have some knowledge about each of these areas, and I think at the least I should at least inquire about these things, maybe not try to tackle every one of them 100%, but at least say something like what gives your life meaning, or even are you religious? Would you like to see a chaplain? Do you have that type of thing? And maybe just go that far, but I don't know if it's still good. What they were suggesting is don't address it at all, but it seems like we have to go
I would
somewhere.
think it would impact your practice if you have a Jehovah's Witness.
Yeah.
I mean, I would think that's something you have to know so that you'll know medically how to treat that person. So yeah, I don't think you could pull that out completely.
I know.
Personally.
That's a good example.
Right, and sometimes you don't always have that team, unfortunately. Joni may go out into her assessment and the patient may die before anybody gets there. So, she has to look at the whole patient because that's what palliative care does.
Right, or I was thinking like, what if you were practicing like frontier medicine and you're the only one there? What if you don't have a chaplain or social worker at your disposal, or if you're kind of like Jane Cornett, who runs who has her own service doing palliative care in the nursing homes. She doesn't have an interdisciplinary team. She sometimes utilizes the ones at the nursing home, but she does a lot of that stuff on her own too. So.
Well, I think what I've found is, I think it's what social workers are good at, is you have a bag of tricks. So as you start practice, you start accumulating relationships and phone numbers and resources, so that you get in a situation like that, okay, I worked with, you know, Jane down, is that, I can't read that font.
Jean, you're very close.
You know, and back when, and, you know, I'll call her, and that's what I do. I mean, I started out in Child Protective Services. Best thing I ever did, because I can't tell you how much I've had to call and, you know, go back to those days to, you know, make contact. So, you know, I think that's what everybody you meet, you got to kind of be mindful of, you know, how are they going to help me down the road? And what do they know that I might need to know? And then some of that is, you don't have to know everything. You just have to know where to go.
Yeah.
You can take your favorite hospice chaplain to lunch.
And the nurse has to go on vacation with any patient.
David, you had something you've been wanting to say?
I think one of the things that we have to be careful of is that oftentimes we go in thinking, I'm going to do this with this patient. I know exactly what needs to be done. And we forget the art of listening to the patient themselves and seeing what they really are concerned about. Because that's the only way we can make the distinction as to who it is they need to have for that particular situation. So I think that's one very important aspect that every team member should understand is the art of listening to that patient, because after all, it is our job to advocate for them in every situation, and they're our purpose, and so I think it's very important that we
Right, absolutely. And you're right, sometimes we go in with our agenda, the checklist, the assessment form, instead of just saying, can you tell me what's going on with you, or what would you like to see happen? You
It's
know.
a mandatory question on our forms now is what's most important to you today.
That's
a
good.
mandatory field. You can't leave that form until you ask that.
And that's so interesting. I think the most powerful example I have of that is that I was the sole person going in to do a consult on a patient, and everybody who told me about the patient emphasized this man's physical pain as being his primary problem, and that's why we were consulted. And when I went in and saw the man, and I asked him how he was doing, and I introduced myself and my role, and I asked him, I'm here to help in whatever way I can. You know, what's the biggest problem that you're facing, or what's first and foremost on your mind that's troubling you the most? And he said, I'm not married to the woman I've been living with for 30 years, and I want to marry her before I die. The physical pain was completely irrelevant to him. And so it took me on a completely different course than I would have gone on if I had just gone in and said, I'm the pain specialist, I understand you have pain, tell me about your pain. By me just starting the conversation that way, we were able to make a huge impact in his life, in his family's life, and the staff too. So I echo David's assertion. I think that is of the utmost importance.
Well, one thing that it does, when you do that, the patient recognizes they have control. They have control over what is going to occur to them, because you know, when a patient gets a prognosis that is a terminal illness, the very first thing they feel is out of control. So the times that we can go in and help them realize that they are in control of this, we should do that often, and listening is one of the best ways to do that.
Absolutely.
And then recognizing what they say, acting on what they requested.
Absolutely.
I think one of my favorite questions, just to get things started with patients, especially people who have lots of health problems and have been kind of going downhill and et cetera, is to just walk in and say, how has it been? How's it been going? Just sit down and listen, and you can get a lot that way. And
Absolutely.
Really, as you said, go in quite different directions.
Right. Okay, well, let's move on and talk a little bit about what can go wrong in a team, or why sometimes teams aren't as perfect as the glowing stories we've heard here. But teams do go through stages, and I'm sure that you as hospice team members have seen and been with teams at different points in the team cycle. teams have to form, of course, and then there's a period of storming where everybody's kind of checking out their turf and their territory and settling in. Then hopefully things kind of normalize and the team is performing at its peak level. But then you get a new team member. Somebody decides to retire or stay home with the babies or whatever and kind of put you back to square one. So is there anything you panel members would like to share about what you've learned about stages and changes in teams?
I'd like to start with that norming. The storming, yes, you're trying to figure out what your place is, what other people's place is, and it can be very disruptive time. And then you've been norming where you're deciding your implicit and explicit rules, and a group may feel they already know what the rules are, or we have written procedures, but it's more than written procedures. It's a little community. There are norms and unstated rules, and if you're new, you don't know that you're insulting someone yet. So norming can be a little unsettling, and then you get performance, and you're working well, and as you say, then something changes, and you're back to informing, and you can skip through stages. You can, it's very, very fluid. For we in the Greek, we recognize it. Acceptance, you don't keep it. You go back into anger, and it's not necessarily a linear progression.
Right. So things change. That's the one thing we know about everything, is that it's going to change at some point. And we need to be sensitive to those new members and what they need to know. And I think also teams need to take time for team evaluation, team growth activities, learning about how they're functioning, working out some of the kinks in the process. And I was wondering if what they do at Hospice to help teams.
We help ourselves personally. They don't do anything to help our team.
Yeah. Oh, okay.
We've really taken it on as our own mission.
Good.
Edit this part.
Do it.
You might want to edit this part.
But I mean, I think we've taken ownership of our own team, and one of the little simple exercises that the social worker, for the one that I'm working with now, we would take 5 minutes at the beginning of our team meeting, and we would always come up with Amy's question of the day. Amy always had a question of the day, and it would be something totally not hospice related, like what's your favorite cake and why. But it made us talk as human beings and people, and we got to know each other. There was a real time limit on it, but we actually, and some of our questions would be quite difficult, and you really had to stop and think, what's the most difficult situation you've faced since you've been here at hospice? So there were some that were just friend forming, and then some were team forming. But that was a really helpful experience for us, and it didn't take much time. We built it in, and we honored it, and we did it every meeting. The one, she was always a question former, and she had a lot of energy, a whole lot more than I do. But she was really good at it, and it really helped our team become a lot more accepting of one another. It helped us to understand when we were all going through our own personal trials. As we all get older, we're all facing ill, dying parents, siblings, spouses, and all that kind of stuff. And when you know what's going on with your teammates, that can help you also have some empathy about, ooh, Joni's probably not very patient today, but maybe there's a reason for that.
So
we took that in, for ourselves, and decided that was how we were going to do teams.
Great.
And I have kind of this similar situation in that team has changed for us recently, big way. It always changes, but this is significant, right? And so we've had to really work at figuring out how can we keep team as we understand team. Because as we all know, the outside forces are really impacting healthcare. So it's impacting everything we do, from documenting to how we have team. And the reason that team works at hospice is because of the way it has traditionally worked. So how do we keep that? And so we just had to work at big thing for our team was just keeping the bereavement part. That was huge, and it didn't have its place in the new model. So we've had to kind of figure out how to do that and still meet the guidelines. So what I wanted to say about some of this is what I've found affects some of that more recently, more than any new people, is change. To me, change can set you back to the very beginning. Depending upon, at least that's what we've had some experience. Not forming as a team, but forming how you're going to do.
Right.
And
so organizational factors and things outside the team's control can really impact the team's functioning and where they are on this continuum. That's a very good point. So it's not just a new member coming in or someone leaving.
The scenario of that is when I went to hospice 20 years ago, our team meetings, we sat around a table. You were not allowed to have any papers, pencils, anything on the desk. You talked. You talked patients. Your team leader wrote a 3-line care plan in the book, but you talked. We talked about every single one of our patients. There was a bereavement counselor present. There was a volunteer coordinator present, and we really shared stories about patients. It was a rich experience and a great learning experience for all the team members. We now have what I call as a data entry session. It's not so much a team meeting as more as everybody's got their heads and hands in the computer. You check them off. You've got 60 minutes to get it done, and you're out the door so the next a group of people can come in. At least that's the way ours is operating. And it's very difficult to maintain that sense of story that binds us all together. And I think for me, that's the piece that's missing. So we do lunch, we have a separate meeting other than team meeting so that we can do stories, that we can help support ourselves through the grieving and the emotional overload that kind of comes with this cumulative grief.
And the article I gave you all by Martha Twaddle, I just think she's an outstanding palliative care physician. But she's really looked at all the research on hospice teams and pulled all that together in that article. And one of the things she says on that is the need to tell stories and not just be hung up on the medical data about a patient, how important that is in team meetings. So I think you really have, I think that those who've been involved with hospice see how much value that has, although, like you say, healthcare is changing, there's time limitations, everything, productivity, and that's the reality of the environment. But we need to keep those interactions, and we need to see our fellow team members as human beings with a life of their own. I think when you really know somebody as a fellow human being, that changes the relationship. They're not just a cog in the wheel that, does this job every day. So that
the question that comes to my mind, the last one of this is performing. I think no matter what stage the team's in, you still have to perform.
Right, that's a good point.
Yes, right.
And the question is, what do I need today to perform well? What do my teammates need from me that will help them perform well? And maybe it's nothing more than getting their coffee for them in the morning. Maybe it's nothing more than saying, let's have lunch.
Right.
Maybe at the death of a child, it's putting an arm around a teammate and not saying a word. Then you go on.
Right.
But we still have to perform.
That's a good point, Jim.
I come back to what's been said over here a couple of times, that the people we work for are those who are dying. And we really get caught up in working for CEOs and whoever's funding us, but we're working for those who are dying. And I think that helps me more than that. How do I perform? How do I do this for the person who's dying?
Right. All right.
Say we give great care despite the organizational barriers being there. And I'm not saying anything bad about the organization, but it's just the way healthcare is now. There are so many challenges, organizational challenges, that we continue to give great care despite those barriers.
Right. I'm going to move on through some of the slides and talk a little bit about managing team conflict. Because it happens, we're humans, and we're going to have these problems, problems of turf. This is what I do and don't you step over the line. Factions can form in teams where you have two members that really buddy up and maybe don't have good relationships with other team members. You can have power struggles. You can have a really strong leader that still sees I as the important letter that's not even in team, right? So how do your teams deal with conflict?
You're the expert.
How do you deal with conflict?
I was joking with Johnny, we have a hole in the floor where we put our heads when conflict arises. I think of what one of the social workers did with me one day. I went into the room, I didn't stay long, and then I went down to get my cup of coffee to serve my addiction. And she came down and asked me point blank if I was upset with her. No, I do have several other things I need to do today, so I really felt rushed when I went in, and I didn't want to get caught in the meeting. But she felt something else, and she brought it to my attention immediately. And that meant that nothing built up over a period of time. She was asking directly for some feedback. We did it, and there's nothing. I think the longer it goes without being addressed, the more there's anger that builds up, and just like in marriage conflict, if it goes long enough, then the anger becomes a problem, whatever the original problem was. I think sometimes that, like for us, one of the difficulties is it's really hard to recruit nurses. I don't think we pay as well as other places do. I don't know that, but that's my perception. And so if there's a conflict that does involve a nurse, there's a problem, because there's an unwillingness to engage that problem with the nurse for fear of being chase somebody else or we get paid better somewhere else. We'd have to go into the hunt and look for somebody. And that produces this, okay, why bother to bring it up kind of thing. When there's really a need to bring it up.
Right.
There's a need to make I statements in this. I felt this way, I see it this way. And not to do the attacking. You did this, you did that. And that doesn't help. Accusations never help. To say, when this occurs, this is how I felt about it. This is what I think. And be willing to put it out there.
Right.
We had a time not long ago with the PEDS team with a patient. The mother wasn't returning phone calls to us. And the nurse got upset and wanted to just discharge them. And I said, no, I don't think so. She's lost one child. She's going to lose another child. I think we need to ask the question, what's going on with her that she's not returning phone calls? And our plan was that I would go and talk with Mom. I had an appointment with her and see where we got from having that direct conversation with her. That was for a Thursday. On a Wednesday, I was on a trip with the pediatric team to go fishing with the kids, and when I got back, I was informed that the nurse had discharged this patient already. And I got really angry. And when our team manager came in and sat down with the nurse, I said, I have real problems with this, because we decided on the process, and we violated our own process. And I don't think that's appropriate at all. We failed to ask the clinical questions. What's going on with this mom that she's not returning phone calls? And they could acknowledge that they got ahead of themselves, but still try to defend it was the right decision to make. But we had it out. It was on the table. It was out there. Rather than just saying, well, that didn't help.
Right. So.
Please don't tell anybody I just told you this.
Well, that, I think we always talk about the elephant in the room, the big death word, but a lot of times it's this anger or this undertone that's going on in the team that people are afraid to put it on the table and really just deal with it and resolve it.
We had severe conflict on an earlier version of one of the teams that I was on that was really, really impacting patient care and the way the whole team was functioning. And we finally asked for an arbiter. We asked for a social work manager person to come in and lead a discussion about all the issues surrounding it. It had to be dealt with. It had to be addressed because we were no longer functioning as an effective team. And that was a very helpful process to have someone outside of the team come in and really lead the conversation and it helped tremendously. But for us to recognize that we needed that it was getting to the point where it was impacting patient care, it just had to happen. So
That's
I think
great.
you have to be willing to speak up and say, we as a team have a problem, we need some help, we may need some outside help to get through this. People were taking stuff personally, and all that kind of stuff.
Right.
You
Right.
know, I think oftentimes when we go to blame people, it's not necessarily the people, it's the process that we should be blaming. Sometimes we don't have a good process in order to bring things before each other. And it sounds like you guys have worked out that process so that you realize we've got to be honest with one another. We've got to get things out on the table. Because if we don't, it'll get in the way of us caring for the patient. So you've learned how to maybe possibly tweak the process rather than tweaking the person or blaming the person.
Right. Good points. So these are some of the other problems you can have with team, and I think we've talked pretty much about all of these. And then sometimes there's patterns of avoidance where team members have secrets within the team, or they're ganging up on another team member either directly or indirectly. There may be some unhealthy agreement where everybody just goes along with the plan, but they really don't think it's the right thing. It's just the easier way to deal with it. And then some people can be very defensive. I think you're vulnerable, like we said, when you're on a team, and it's easy to be defensive when someone brings something to your attention or it seems to be critical of your work. So how do you deal with those things? I think you've already talked about, we bring it out, we try to be direct. If we need help, we go get help in resolving the problem. Anything else that would be helpful there?
We're all so old, we're really direct.
Yeah, you know, I know, but it's probably much harder for a younger person earlier in their career to be able to really put voice to some of the things that need to be dealt with, and do it in a way that's, like Jim said, the I messages, not making it confrontative, but really just putting it on the table so everybody can talk about it. But we do see these things happen in teams, and it's important that we have that sense of awareness and looking at our team and how it's functioning. We're going to have conflict, we know that. I know that I'm a conflict avoider, and that's not always good. I kind of was scripted into that, and I'm working on that all the time to be more direct. But I think sometimes this is what that SCAR quotation had to do with, really looking at yourself and knowing yourself, because if you're working in a team, you really have to have that self-knowledge and know where you're vulnerable, know what your issues are, so that you can work on those as you interface with other people, and through that you are more empathetic towards some of their issues also. So, a healthy team. These are the characteristics of a healthy team according to Dale Larson, and I strongly recommend his book. It's gotten very old now. He wrote it in the 80s, The Helper's Journey, but it's a wonderful book, especially for new people going into palliative care, because it really talks about boundaries and not being drawn into the pit with the patient, and all the energy we bring to the job. So many times, because we have so much fire, we can burn out if we're not careful. So we have to learn how to set our limits. But healthy teams have shared goals. Like we said, they're clear. Everybody knows their role. Intelligence of a team, and this is what I was kind of getting at, where the team studies itself. It looks like how it's doing. It might be evaluating those patient outcomes. How could we have done better in this case? Constantly being in touch with the work of the team. There's trust and goodwill, so people can be really honest and forthright with each other. Conflict is addressed and resolved. There's minimal secrecy and gossip. There's shared leadership. There's not a hierarchy in a good team. There's technical and emotional support for team members, and the team feels like they're accomplishing their goals. Would you panel members add anything to that list of healthy team characteristics?
I put down, don't take it all personally when you're in teams that are stressors.
Right.
People are under a lot of stress and get all the outside stressors.
Mm-hmm.
You just have to get to a point where you don't take it personally if it isn't said just the right way. And
Right, right. And the work itself is so stressful. Even outside, even if you had that perfect family life, which not many of us have, but there's so much stress involved in the job, I think. And we're all susceptible to the emotions related to that.
I think one of the questions to ask ourselves is what assumptions am I bringing that I'm not fully aware of and my teammates are not aware of?
Mm-hmm.
What assumptions do they bring? Somebody comes to begin work with us and has been in a hospital setting, I think they've probably been working in a hierarchical setting.
Mm-hmm.
And they come kind of expecting that without realizing they're expecting that.
Right.
And then they're automatically seeing somebody's lower on the totem pole.
Mm.
And that's felt without being understood.
Mm-hmm.
And so just asking those questions. And I'm also into that, who am I for this person, who are they for me? I think those are important questions to ask for the team.
That's a good point. Mm-hmm.
I think one of the things that's really important is being able to laugh.
Mm.
Yes.
Mm-hmm.
One of the things that goes so badly wrong, you just have to laugh. Or there's some that patients are so out left field that you gotta laugh too. And one of the ones that we just laughed, well, I guess Becky and I were really the only ones who were around back then. But this lady who was, oh my gosh, she had so many chronic health problems, and she was like a bilateral above the knee amputee who wanted to go back and live in her trailer alone. It was just such an unreasonable request. I mean, there was no family, no nothing. And we're like, well, but what happens if something happens to you? And she says, I have a cat and I'll train it to dial 911. And
oh, yeah. You know, I was looking at quotations about teams and teamwork, and one of them was, if you can laugh together, you can work together. So I think that's one thing that's missing is having fun.
Yeah.
You know, healthy teams, I think, do enjoy each other, and they have fun.
Our work can be so serious and so somber, and I think that you run the risk of being too serious and too cynical and just lightening up and loosening up, but not being so hard on everybody and everything is really important too.
Mm-hmm.
And not assuming where a certain emotion's coming from, for example, and I like that, just suspending judgment and trying to understand more what's behind the emotion.
Absolutely.
One of the things that I've seen that's most detrimental to teamwork is complaints.
It's what?
Complaining.
Complaining.
Mm-hmm.
Oftentimes people get together and they have common things to complain about, and they'll spend a lot of time complaining. And what you, I think, need to do as a team, you need to try to redirect that energy used for complaining to coming up with solutions for what you're complaining about.
Mm-hmm. Mm-hmm.
And so I think that can tear down teamwork quicker than anything.
Right.
But if you realize that,
negative whirlpool.
yeah,
Yes,
realize
yes.
that you can redirect that energy to bring about solutions.
Right. Or if you can't, sometimes you have to accept the situation and decide we're going to work in spite of this, or we can't change this right now, so let's change something we can right
We
now.
know we have to do the data entry. We know it's a requirement. We've got to do it. We've just had to figure out ways to do it that still allows us to talk.
Right,
So we
right.
problem solve those things and
Very good. Yeah.
move past those so that we can still have enough time to tell stories. We're getting our stories in.
Great. You've talked some about your team meeting, and I think the idea of rituals sometimes is very helpful for a team. Rituals of remembrance or sharing. I know Martha Twaddle, I keep mentioning her, but she talked about her team. She has a palliative care team in the hospital, and apparently it's a good team, but whenever they're getting ready to do a family meeting, they stop for a moment of meditation, just clearing themselves. and being present in the moment before they go into a room for a family meeting. And I think just the fact that they're able to do that as a team and know that's important says a lot for their team. Any other rituals or team practices that are helpful? Do you ever have a retreat? I know you eat a lot, but go out for lunch, have a potluck.
We do all those things.
Yes.
One of the things we do as a ritual now is we're rather irreverent on our team. We just are, and we have a box.
Reverend.
We have a box. It's just an old cardboard box. Our team leader, she really wanted us to have a nice, urn.
Right.
to do a bereavement ritual type thing. Well, since we're irreverent, we have an old discarded paper cardboard box, and we write words or thoughts or whatever on maybe an obituary that somebody cut out or a scrap piece of paper, and we wad them up and we throw them in the box, about this patient. And that may seem irreverent, but to us it's a fun way of remembering these people and saying, he died all alone, just by himself, just the way he wanted to. I had a man that died yesterday who did not want anybody there, and he died all by himself just the way he wanted to, quickly. And, that's what I'm going to write on this piece of paper, and I'm going to throw it in the box. That's a ritual that we use, but we also use it to tell stories and to say a word or two about someone who has died.
Great.
Sometimes on the pediatric team, go on to lunch after the death or after the funeral for a child with death of some kind. And the lunch is in honor of that child.
Oh. Mm-hmm.
So we're feeding ourselves, also nurturing our own spirits at that time.
Great. Okay. We've covered a lot of ground, and this has really been rich. Are there any closing comments? Because I do want to honor our time commitment of our panel members. They've been so good to come and share with us. Is there any last advice you'd like to give the group, or words of wisdom? If not, let's just give them a big round of applause for sharing their time and expertise with us today.